Thank you, Kosikon, for this invitation. I'm going to be talking about post-operative care during limb lengthening. There's a very important difference between fixators and standard surgery. In standard surgery, the moment you've done, the suturing, your surgery is over, and then you don't really need to take as much care. Whereas with a fixator, the surgery really ends only with removal of the fixator, and it's a question of months in terms of when we're doing a lengthening versus a couple of hours when you're doing other surgery. So there are four basic principles which we should pay a lot of attention to. One is prevention of contractures. Second is the pin side care because these fixators are on for a long time. The third is mobilization, physiotherapy, and a splint. And finally, maintenance of the fixator. That is changes that you may need to make during the time that the fixator is on the limb. So right after surgery, limb positioning is something that needs to be taught to the patient. Otherwise, they tend to keep the limb in a way where the under the knee, so that that develops a kind of flexion deformity. They have to be taught to keep the pillow under only the distal ring and keep a free space under the knee so that there is space for the knee to extend. And the ankle should always be kept in dorsiflexion with this kind of a splint. Very simple to make. Any local cobbler can just add these two Velcro straps to a floater and you can prevent equinus with that. In terms of physiotherapy, we concentrate on active movements of the hip, knee, and the ankle, especially when you have muscles crossing two joints. Both joints should be neutral at the same time. Otherwise, if you correct in one, it compensates in the other. Like if you correct the equinus, they will develop a flexion at the knee due to the gastrosoleus. And this can be by passive stretching. And pay a lot of attention to early ambulation, gait, the way they walk, and weight bearing. Insights, this kind of problem is preventable if you do a proper, start-stop technique, avoid thermal injury, like this pin sequestrum which was formed. But in terms of long-term retention, I think the most important thing is regular pin side care, which is taught to the patient because they can do it much better than any doctor and they will spend whatever time is needed. I prefer boiled and cooled water, no medications. We use sterile gauze pieces, of course, but otherwise the focus is on cleanliness and not sterility. Thorough hand wash, patient does, dips the gauze piece in the boiled and cooled water, squeeze it out, stretch it, and then clean all the crusts around the pins. If the crusts are removed and any exudate comes out, the chances of infection are less. And then they just wrap it with a dry gauze piece. No ointments because ointments will just tend to block exudate from coming out. We in fact have a video on YouTube for this and we give the link for this to every patient to do the pin side care according to that video. So these are pin sides at 3 months, 4 months when they have been taken care of. No sign of loosening, no sign of inflammation. Even when you look at the X-ray, the bone is well apposed. There is no lysis around, and that's how it should be. In case of the femur, you can reduce pin skin motion by using a couple of hand towels, Turkish towels, which are the smaller size. Cut them in half. They can be sterilized by boiling, and they can be reused. Basically, when you put this in between the fixator and the skin, that reduces the pin skin motion, and these pieces can be reused again and again. Pain is one of the aspects of application of fixator which tends to sort of create trouble for patients. You can have distraction pain, which is usually more in the evening, night, because during the daytime they have other stimuli which are distracting them. You can use ice packs. You can break up the distraction. Give a couple of 1 day's break every week or so. Use appropriate pain medication, in which I prefer to use paracetamol. The other pain that patients have is a tension pain because of skin tension or because of loss of tension of the wire. And finally, the thing which can happen is instability. So pin side tenting, when you have put pins in a particular direction and then you have moved them, there is tension on skin and this should be released immediately after insertion. This may also happen with distraction. And in the OPD with a little bit of local, that pin side tenting can be reduced. But if you have instability pain, like this, where the fixator is very not stable, then obviously you need to put the fixation. If you have an infected pin side, which is showing increased discharge, which is purulent, redness, there is swelling, you can, first thing that we normally would do is increase the cleaning, ensure that they are following the protocol that has been taught. If that does not work, then we would start them on antibiotics. In some situations, even without infection, there can be a loosening. Of course, with infection, there can be loosening. So when you change the pin, if your infection is continuing despite your starting antibiotics, etc., if there's a large area of lysis around the pins, because that means the pin or wire is not holding the bone. If you have a large lytic area, there is a future risk of a pathological fracture. And if healing is still a while away, then you should change the pin. Or if healing is, it's almost healed, then you can just take out the pin, because that will work as reducing the stability of the frame. So here's a case where you can see clearly in this area, in the distal pin, there is lysis there. So in this area, there is lysis. So this is not really doing anything for the stability. So this kind of pin needs to be changed. Here's another one where we can see lysis, but this was a bone transport. There's no healing happening here. So there's no way that I can take out the pin over here. So here it has to be changed. So, at 3 months post docking, clearly you can see lysis. That's a close-up view of that. But at the same time, notice that there is no real infection over here. So this is a sort of aseptic loosening, which can happen in these areas. So we've changed the pins from the original areas to different areas, freshened the non-union site and did a bone graft over there. And over time, this goes on to heal progressively. So change pins as and when needed. Don't hesitate to do that. Other specific interventions that you may need to do are to speed up the distraction sometimes if you see signs of premature consolidation. Slow down distraction if healing is not happening appropriately. You may need to change distractors once you get to length. And if you've lost tension and patient has pain, you may need to retension the wires. For removal, usually what I like to do is in the later third of consolidation, we will back off the nuts a little bit by 2 or 3 millimeters. So what we're doing essentially is that the tensile force on the fixator is removed and the regenerate loading is better and therefore ossification is better. I have this golden rule of a month too late is better than a day too early. You should see 3 cortices. You can see the lateral cortex well formed here. You can see the medial and lateral, and the posterior. AP anterior cortex may not be as good, but this is okay. So 3 cortices should be seen, full function, and what I call a stress test. So this is a ready for removal gait. Patient is walking practically normally, and you can see that the rail has been disconnected. And even in this patient, you will see the fixator also gait is practically normal. Another one. So now here, the next thing that we do is disconnect the proximal and distal fixation parts. The first ring and the second ring don't have any rods between them. So essentially now the patient is walking on the bone. If the patient has no pain, no change in the gait, then you can remove. Usually I don't use an external support. However, when in doubt, I have no hesitation to use an external or internal support, especially in congenital cases where we are doing lengthening. So this is an X-ray which seems to be okay for removal. Patient was walking well. However, because I was not totally satisfied with this regenerate over here, I decided to protect it with an internal splint in the form of a TENS nail. And He did fall down. He broke it, but because the nail was inside, there was no displacement, and in fact, he healed with even more exuberant callus. So he healed without any further issues over there. When you remove it, we loosen the central bolts, we detension the wires, we cut the wires. Always detension the wires before cutting them, otherwise it's painful. And then remove the rings in a clamshell fashion. We use local anesthesia for olive wires, and in children, we would always use a general anesthetic. So in summary, surgery only ends in terms of lengthening after the frame removal. You should pay attention to prevention of contracture, promotion of range of motion, and the muscle strength should be maintained. Teach the patient pin site care to ensure longevity of the pin sites and keep a close follow. Thank you.